try to discuss a little bit what is broadly discussed in this conference extensively. I will only try to touch a little bit on everything because of time. So, respiratory failure, we define it as abnormal blood gases, and then we use the positive pressure ventilation to correct blood gases. When we apply positive pressure ventilation, we affect several other things, such as intrathoracic pressures and heart-lung interactions, alveolar distension and distribution of ventilation in the lung, the breathing pattern and the brain response to this, and of course the respiratory muscles. So when I was preparing this talk, I was able to come up with at least 10 ways we can cause injury with the ventilation. Maybe you can think of other ways. I will briefly discuss on some thoughts on those and what we could do to minimize injury. Most is not based mostly on physiology. So, injury from hyperinflation, this is the most well-studied. We can actually hyperinflate the alveoli to the point of rupture, and that's what we call barotrauma, but even excessive hyperinflation without breaking the alveoli can cause local inflammation. This can also spill over to the systemic circulation and be systemic inflammation and can cause distal organ injury. And of course, these hyperinflated alveoli are zone 1, so it's dead space ventilation, wasted ventilation that further increases ventilatory demands. What to do about it? Well, avoid high tidal volume ventilation, promote lung homogeneity, and reduce ventilatory demands. Avoid high tidal volume. So we've known for over 20 years now that it's better to ventilate patients with 6 ml per kilogram rather than 12 ml per kilogram. What we have learned more recently is that in a patient who is breathing spontaneously, when the tidal volume is relatively normal, strenuous breathing can divert the air within the lung to the more dependent regions and can cause injury, like, you see my pointer? No. Is there a pointer or? With your finger? Okay. So, like here in an animal model, you can see air, the animal is breathing spontaneously, so that you see more air in the dependent regions and more inflammation in the same regions. Another animal villi model, spontaneous breathing can cause more injury here in the dependent regions compared to the non-dependent regions or animals without strenuous breathing. So not just avoiding high tidal volume, but considering how the patient is distributing the volume within the lungs and consider that strenuous breathing may be injurious. How about promoting lung homogeneity? We have been using PEEP for several decades now in an effort to achieve exactly that, a more uniform distribution of ventilation, as you can see here, during inspiration and expiration. A low and inappropriately low level of PEEP will allow the lung to collapse and the ventilation will not be just as equal. Is that universally good? Unfortunately not. There are patients in whom when we apply PEEP, it just over-distends the healthy regions and the atelectatic lung remains closed. What else can we do? Prone. Prone position allows a better homogeneity of the lung, and it's safe, and clinical studies have shown that it indeed reduces mortality, so we should use it in patients with moderate and severe ARDS. How about reducing ventilatory demands? Since ventilation is difficult to achieve, why have more of it when we can have less? As the PCO2 equation dictates, PCO2 depends on the CO2 production, minute ventilation, and dead space to tidal volume ratios. So you may always have to remember that you should decrease CO2 production, like minimizing fever, shivering, agitation, etc., and reduce instrumental dead space, like by using, for example, a humidifier. If you cannot get rid of CO2, maybe you can consider accepting it, so permissive hypercapnia. This is also not free of charge. It comes with certain complications and implications. So we will have, when we have higher CO2, we can have pulmonary vasoconstriction. We will have right shift of the hemoglobin dissociation curve, increased ventilatory drive, so the patient may need extra sedation. Also, hypercapnia is associated with anti-inflammatory properties, impaired bacterial killing, and impaired wound healing. So if you don't like the CO2 2, you may consider removing it with an extracorporeal filter. It's feasible now. It remains to be seen the clinical setting to which patient and which condition it will be also beneficial in terms of outcome. Not only you have to avoid the alveoli from being hyperinflated, but also you have to avoid the alveoli closing permanently or cyclically, because it also induces barotrauma. The closed alveoli shifts the air to the adjuvant, acting as a stress raiser. It causes vacuum mismatch and then shunt and impairs oxygenation. And of course, it makes the lung more of a baby lung, so the rest of the lung can be hyperinflated. So when we have high PEEP or we ventilate a small lung with large volume, we have high intrathoracic pressures, and that can decrease venous return and impair cardiac output. It will increase right ventricular afterload. You can see a heart here, the right ventricle dilated more even than the left ventricle in an ARDS patient. And when we try to overcome the decreased cardiac output, we may give fluids. And when the permeability is high, we will end up deteriorating the pulmonary edema. And in the occasional patient with intracranial hypertension, the increased intrathoracic pressure will make things worse. So what to do about it? We're looking for the best PEEP of all. Unfortunately, this is a very large issue, and we haven't found it yet. PEEP opens the alveoli, and it does that so in kind of continuous way. So there's no magic number. There's no 5 or 10 or 15 PEEP that opens the alveoli, but it rather continues to much higher values. The higher the PEEP, the higher the transpulmonary and expiratory pressure, the less the atelectasis and vice versa, but this comes at a price. The more you open alveoli, the more you are at risk of overdistending the alveoli in the non-dependent regions. What has been nicely shown is that a good surrogate for the overdistension of the non-dependent region is the end inspiratory transpulmonary pressure, especially when you calculate it with the elastance ratio. The important point here is that there is not one good PEEP or one good for everyone, not one even good for the same person. We are looking for a compromise that will achieve the maximum recruitment with a minimum overdistension, minimizing the hemodynamics effect to optimize the oxygenation effects. So let's move on from pressures. Passive ventilation and diaphragm rest is another cause of injury because our diaphragm is not meant to rest. It's meant to work 24/7 for as long as we live. And it has been nicely shown for over 10 years now that even hours of passive mechanical ventilation can lead to disused diaphragm atrophy. We can evaluate that with ultrasound, and as nicely shown here, progressive use of controlled mechanical ventilation leads to loss of thickening fraction of the diaphragm, and this has been associated with adverse patient outcome. So what can we do about it? Promote early spontaneous breathing. Is breathing spontaneously enough? Unfortunately not. This is one of our patients ventilated in pressure support mode, and here is esophageal pressure. And you can see here that increasing pressure support makes the patient just trigger the ventilator, and then esophageal pressure rises, so the patient is ventilated practically passively throughout inspiration. How can this happen? Because with pressure support and assist volume, we can provide adequate ventilation to satisfy the brain demands in terms of PCO2, so the brain says that I don't need more ventilation, so I don't need to make my muscles work. So there's no drive. And so we can have muscle atrophy and weakness. As nicely shown here, controlled ventilation impairs diaphragm thickening fraction, but also does high assist, much more than unassisted breathing. What to do about it? Again, consider decreasing assist. Over-assisting spontaneous breath can have another important complication. By increasing assist, we decrease PCO2, and once the apneic threshold is reached, the patient may develop apneas, as nicely shown in this paper of 20 years ago. With a pressure support of 8, the patient develops apneas. Apneas and periodic breathing can lead to sleep fragmentation with the known adverse effects, But also, it often leads the physician to think that the patient is not ready for weaning and switch back to controlled ventilation, thus prolonging the weaning process and having the patient exposed to the adverse effects of mechanical ventilation for a longer period of time. What to do? Again, consider decreasing assist. Mismatch of the mechanical and neural timing of the breath is another way we can harm the patient with the ventilator. Asynchronous can affect both the lung and the diaphragm. As shown here, this is a double triggering, so the patient triggers with one effort twice, the ventilator twice, so receives double the volume we were intending to give, so it's a risk of hyperinflation injury. In this case here, this is a premature cycling, so the patient effort expands into the mechanical expiration, so in this case, the diaphragm contracts while lengthening, and this is known to be an injurious pattern for the muscle. So asynchronous can also lead to prolonged mechanical ventilation. This has been shown, and again, the same vicious cycle. What to do about it? Monitor waveforms for asynchronous. When things look strange or you're not sure, consider esophageal pressure monitoring, which is the best tool to identify asynchronous, and consider using proportional modes which have been associated with less asynchrony. Another problem, ineffective efforts. This is a characteristic example, again, from one of our patients. This is an ineffective effort. The patient is trying to breathe but not triggering the ventilator. Ineffective efforts, especially when they occur in clusters, are associated with prolonged ICU stay, prolonged mechanical ventilation, and again, we have the same vicious cycle of more ventilation, more complications. What causes ineffective efforts? High tidal volume and dynamic hyperinflation is one common cause. Low muscle pressure and low respiratory drive is another reason for ineffective efforts. Insensitive triggering can exacerbate both phenomena. What to do about it? Decrease assist in the first case of high tidal volume and hyperinflation, increase triggering sensitivity, decrease sedation, and correct metabolic alkalosis to correct respiratory drive, and of course, monitoring for ineffective efforts. Under assist spontaneous breath, then we have a patient with respiratory distress. This can cause injury to the diaphragm, but probably will make the patient suffer and have a stress response, maybe post-traumatic stress, will probably not be able to sleep. I guess this is an easy fix, increase assist. Unfortunately, if you go to the bedside and find the perfect assist at 10 o'clock or 11 in the morning, if you maintain the same assist all day, you are probably going to over and under assist the patient throughout the day, because patients' ventilatory demands change throughout the day, and these are data from a recent study we published, and this is minute ventilation through 24 hours, and you can see that it fluctuates between 7 and 12 liters per minute, and with spikes higher than that. The coefficient of variation of tidal volume was above 20% in that study, so our patients are unstable in their breathing pattern as they are unstable in pretty much every parameter. That's why they're in the ICU. So what can we do? Check frequently and consider using proportional modes that adapt to the patient's demands more than classic modes of assist. One more problem, self-inflicted lung injury. The patient with a high respiratory drive and a low lung compliance is at risk of injuring his lung with his spontaneous effort. This is a case report of a patient on ECMO with a chest wall with a respiratory system compliance of 15, who was able, when switched to assisted breathing, to generate with his muscles a pressure gradient of 30 centimeters of water, and of course this is an injurious pattern of breathing. In a recent study, studying patients on PAV for 2 or 3 days during assisted ventilation, we found that patients were developing high driving pressure above 15 only when their lung compliance was very low. The threshold we identified was at 30, and you can see here the orange dots, and the red dots are patients with a compliance below 20. There were very few of those, but they all had high driving pressure. When compliance was greater than 30, most patients were not, all patients were not developing high driving pressures, and several were breathing with tidal volume much greater than 8 ml per kilogram. What to do about self-inflicted lung injury? Manage conditions that affect respiratory drive, pain, and metabolic acidosis. When lung mechanics are severely impaired, then maybe the patient does not fulfill the definition of the condition has improved, so you can advance to weaning. If you still want to advance to weaning, consider monitoring the systemic pressures in these patients. And finally, decreased respiratory drive can be an issue for our patients. The respiratory drive is decreased when we have hyperoxemia, when we have metabolic alkalosis, and when we have sedation. Weak drive means weak effort, and weak effort can lead to diaphragm atrophy, ineffective efforts, apneas, and overall a prolonged mechanical ventilation. So to summarize, when we ventilate our patients in the ICU, we have to avoid injury from hyperinflation and collapse. We have to think about limiting tidal volume both in control and in spontaneously breathing patients. And we have to optimize PEEP. We have to avoid disuse diaphragm atrophy, promoting spontaneous breathing. But we also have to maintain patient effort, not too high, not too low. We haven't defined those thresholds yet. Optimize patient-ventilator interaction. We have to match ventilation with demands. And on top of that, we have to optimize these demands, not too high, not too low. We have to match the neural and the mechanical timing of the breath. Well, if you think about it, if you were 70 years ago in Copenhagen during the polio epidemics, you would have to back ventilate patients for about 6 months. Now you sit in the comfort of your ICU and the modern ventilator is doing that for you. So this is a short list compared to that, what you have to think about. So remember that mechanical ventilation is a supportive strategy, not a treatment. So it's very important to first do no harm. In Greek, ophelein imi vlaptin. Thank you very much.
It's time for some questions, comments. Yeah, but sometimes it's difficult to minimize injury from mechanical ventilation when mechanical ventilation is needed to provide gas exchange.
Indeed.
So what do you do then? What would you predict will happen in the next few years in terms of clinical research? Can we replace mechanical ventilation with something else?
We can minimize the injurious patterns of ventilation. I don't think we will replace it, at least not anytime soon.
So you don't see an option, at least in some subset of patients, where we can foresee extracorporeal support as an alternative to mechanical ventilation?
I think a major breakthrough in the how filters are applied is needed so that we can make it much more safe for the patient to be on ECMO. But that's just my impression. But if we are at some point able to keep the patient completely awake, mobilized, and breathing in a more calm way during ECMO, that would be probably the way to minimize all injury. But I think we are quite away from that yet.
Okay. If we know further, no.